I have the privilege of introducing our speaker this afternoon, Trish Veda. And Trish is going to speak on this afternoon what impacts youth health and wellness. I like to consider Trish as a friend of ours in the community, and her degrees are wide and many as a ER nurse and also as the Enfield Public School nurse through 2015 and supervisor also through 2015. And I love that Trish has such passion for the work that she does, and so we're anxious to hear what Trish is going to share with us. Let's welcome her.
I have to kind of like change my thinking because I've just done kindergarten registration for 4 hours. So go on to something else here. But just when I had a break over there, there's a lot of talk going on around the school nurses right now about the Narcan. And evidently, Mylan, who makes the nasal spray Narcan, will give it free to high schools. Yeah, which is the first I just saw of that before I came over. So there's a little controversy as to whether it's as effective as the injection, and certainly not as effective as when you can give it intravenously, but.
Any barriers in getting that into our schools?
Exactly, yeah. Yeah, so I'll be curious to talk to Gary Wilmokley about it and see what he thinks, because when I approached it a couple of years ago, he was not an advocate of it, but a lot's changed since that conversation. So we can. Is it easier if I flip?
Whatever you're more comfortable with.
I can just. Just want to make sure I get. So basically, what I thought I would do is just talk to you about in the summer every year, I teach a 3-day class to school nurses on how to handle emergencies in the schools. Given my background of having done both. The course has been around for about 30 years because I took it when I first started in the late 80s, and then I went on to be a teacher for it. But we didn't have mental health in it when the course first started, which was sort of unfortunate, but of course now that we see more of it is just so much more important. So basically we're going to just kind of go through the ones that we see in our youth, and then I'll go through some stuff as to how you can do, like we did in the mental health first aid class, to know the difference between what's developmentally normal and what is something we really need to look out for. So the most common ones that we see are depression, bipolar, or what we used to call manic depressive, anxiety disorders, which is the most common one we see in the secondary and causes a lot of students not to be able to come to school. Eating disorders, substance abuse, self-injury, and the attention deficit and hyperactivity. So with depression and bipolar, depression is not always something that someone is going to deal with for the rest of their lives. It can just be situational. They can have a clinical depression. We see that, unfortunately, in our secondary students, especially that have gone through like a really bad bout with mono. Something like that will cause a clinical or a chemical imbalance to happen. As always, we see sadness, anger, violence, different rebellious acts. Truancy is certainly a big one. And then with the bipolar, or like I said before, what we used to call manic depressive, we're seeing the mood swings, the rapid or mixed cycling, and these are people that are at much higher risk of suicide. There's a theory out there now that says that toddlers and elementary kids that are diagnosed with ADHD, and then when they get to secondary, they then get diagnosed with depression and eventually get diagnosed with bipolar. And whether that will play out, we don't really know yet. We're just doing the research on it. I have had the unfortunate thing of actually seeing someone switch from depression to bipolar. I had a patient once in the emergency room who came in with like a spiral notebook just with pages and pages and pages and stuff that he had written just very recently. And then we had a student actually at the high school with a known depressive diagnosis, and just literally on his way to school, he flipped. And I remember him so vividly in the emergency room, in the nurse's office, and the parents were just, so distraught. That was not the child that got on the bus in the morning, and why did that happen to him? But he was very, very classic. For whatever reason, he had, that little magazine you can get as you're walking out of the grocery store, and he was buying everybody cars. It was one of those car ones, and just talking a mile a minute and doing all of that. He was very classic for it. So the anxiety orders. This is the one that is just truly, truly become such a problem. I got such a better understanding, when I'm on all these different little listservs. I had gotten one that they did a little mini lecture series, and anytime it's for free and they feed me, it's always a good thing to go to. But it basically was for daycare providers and teaching them about, it was called Mental Health in Toddlers and Infants. It was absolutely fascinating. They asked me, why was I there? I was a nurse. And I said, I never learned this kind of stuff in nursing school. But it was just the little things that you kind of don't think about. So it's the way a parent reacts to something that happens to their child. So you have a toddler, say, 9 months old, and they're just starting to climb and walk or whatever, and they fall and they whack their head. Now, a parent who says, oh, get up, you're fine, and scratches their little head or whatever, that's the really way to go. But the parent who panics and is like, oh my gosh, and is immediately on the phone with the pediatrician saying, Johnny fell and hit their head, and what do I do, and whatever, the child picks up on that. And over time, they think that's how we deal with everything. And then it actually can become the disorder for them. And I thought that was just such an easy way to understand, when they say that parents should have manuals and stuff, that would be a good one to have with that. So with our anxiety disorders, they have phobias. Panic disorder is the big one. We've had kids so anxious about going to school that they literally cannot come in the door. The mother will drive up in the car, the father, whoever, they can't get out, or they can't on times get off the bus. It can certainly be from post-traumatic stress disorder, and certainly with the obsessive compulsive disorder. And that obsessive compulsive disorder really has many varying degrees with that. So the student that, has to have the perfect in paper, that kind of a thing is not as bad as the student who writes the paper over and over and over again. Or, the sort of classic one of cleaning a doorknob before they can go in. We also, unfortunately, are seeing a lot of the disruptive behavior disorders. So these are the ones that get diagnosed as being either oppositional defiant disorder or a conduct disorder. And certainly for that, they would have some testing done to determine that. And that's very different from them just being behavioral issues, if they have a true diagnosis versus a learned behavior. Eating disorders, we always think of especially our teenage girls with anorexia and the bulimia or the binge eating disorder. But now there's actually more diagnoses with this. When I got to be the supervisor and my office was at Fermi, I was shocked. I never thought about boys and anorexia. But I learned about the wrestlers and all the things they would do to get their weight, to be able to wrestle at that given weight. And that was a real eye-opener for me. The binge eating disorders are the people that do like she does, where you just eat a lot all at once. The other one that they're seeing now is the people that have to eat the same exact meal every day. Every meal, they never waver from it because they're so afraid they'll gain an ounce. So that's one of the newer ones they're seeing. Substance abuse, certainly we do see that. You can, for some kids, see where it goes from being a good student, all of a sudden you're seeing they're not hanging around with the same kids, they don't have the same relationships, their schoolwork starts to fail. As we know, we're seeing the physical dependence on it, emotional and psychological dependence. What we're seeing now with the prescription drugs, and part of that certainly is because in high school we get so many kids that have their wisdom teeth taken out and get a prescription for like 30 Percocet. So inappropriate. In the school system, what we've done for years is we have an assessment tool that we do, and no matter who the child is, whether it's somebody we know that has a problem or the first time we're seeing somebody, everybody gets the same assessment so that nobody can say we're not doing it fairly. And we keep that in their record. The self-injury with the hair pulling, the cutting, scratching, biting, burning of their skin, picking at their skin, kids even that you see that have, it starts as a hangnail, but if you look at them closely, they have no skin around the ends of their fingers. The self-inflicted tattooing and body piercing. When I first started at the high school, we used to have safety pins in the office for when people had clothing emergencies. And we actually had to stop that because they were piercing themselves with them. And we would get called to a class because they had safety pins all over their hands and things. Certainly, some of the self-injury can be just because of their reckless activities. They think they're infallible. It's not going to happen to them. And certainly, if they already have a diagnosed mental health problem, they can do something reckless that's part of that. The self-injury one is always very interesting. When I did research, I also do for the State Department of Ed, we have a thing called the Cadre of Professional Nurse Educators. And we go around, we have different subjects that we teach school nurses about. And I did one on self-injury. And when I was looking for the research, all the research was at colleges, because it is huge at colleges, much more than we see in the school systems. But when we do have it, it can be really tough because most people that are doing self-injury will do it so the parents don't see it. And then when it gets brought to our attention and we have to bring them in and talk to them about it, there's very often disbelief with that. So usually we do have to work with the parents on that one. And you can get some kids with a self-injury who have been doing it for years, and unfortunately the parents don't know. The attention deficit hyperactive disorder is the kids that you see that are all over the place. They're inattentive, they're easily distracted, they can't finish their tasks, they can't follow instructions. They very commonly, you can't say to them, go downstairs and get me a can of soda. They can't have two instructions. They'll go downstairs and they'll be like, what did I come down here for? So you have to work with them on that. They're restless and fidgety. They interrupt conversations. They grab. Sometimes they can be a combination of both. One of the problems that we have in the school system, unfortunately, is that with the long-acting medications now, previously when we just had Ritalin and the kids were all showing up in the nurse's office at lunchtime, everybody kind of, could guess if they didn't from the child's behaviors. But now with the long-acting, the parents often don't even let us know. And then that can be an issue both sides. But people have different feelings about that. There's a new one out there now where, essential oils have become very popular. And we actually had a parent who wanted the school nurse to rub lavender oil on her child's feet during the school day to help with his attention deficit disorder. So one of the things that we do is that we always have to do a systematic assessment. So, what students and people don't realize is that when the student walks in the office, the nurse is automatically doing an assessment. We do what's known as a head to toe, and we're looking at all kinds of things. They may think we're standing there doing nothing, but that's really not the case. But as with everything, scene safety is the first thing, doing that across the room assessment, like I said, then doing the initial assessment, the airway, breathing, their circulation, and then you do the focused assessment. So obviously if they walk in and they're bleeding, you're looking to see what's bleeding, that kind of a thing. So we use different ways of assessing them, and we use what's called a sample. It's I can never say this word right, mnemonic as a starting point. We ask what medications they're taking. We look to see if they're on any psychiatric medications. We look at their past medical history, and then we use some screening tools. So this is what we call the mental status exam. And this is part of what we're doing when we do that head to toe. And I think this one to me is so important because one of the saddest stories I ever heard was from a teacher who had had a former student working at a drugstore. And after he committed suicide, I remember her talking about the things that she had noticed had changed when she would go into that drugstore, which was exactly part of that. And that was kind of the reason why I picked it to do for today. And, she'd said to herself, if only I had said something to somebody and realized that was what was going on. So when we're looking at that student or a friend or whoever it is, you're always looking to see what their appearance is and whether any of their grooming, their posture, their cleanliness has changed. You look at their mood. Are they frightened? Are they their usual relaxed self? Or are they really irritable? When you listen to their speech, you're looking to see if their words are slurred. Are they faster than usual? Are they louder than usual? Is there a tone in their voice? And the big thing with behavior, are they slouched over? Are they pacing about the room? And will they make eye contact with you? That's probably one of the most key ones, is whether or not they'll make eye contact. Oops. Sorry about that. So then, after we've looked at them physically, we start asking questions to see whether or not we think they're at risk. So we might ask questions about the home environment, and especially at the secondary level, that can often be a big one. We have, unfortunately, kids that are kicked out of the house, living with other people, those kind of things that don't come up in the day-to-day conversation. We talk about their education and their employment, ask about eating and exercise, ask about their relationships with their peers and what kind of activities they're doing. And it's not like we just really ask the questions, but you just sort of incorporate it into the conversation. Trying to see whether they're into nicotine or alcohol. Sometimes it can be part of what's going on with them as they're trying to decide about their sexuality. We do have different tools that we can use for suicide, depression, and mood screen. But the bottom line is you always want to make sure for their safety. When we're doing a suicide in the schools, the scene safety, of course, is always what we start with. And we always want to look to see if there's any kind of weapons. We use the mnemonic that I talked about before. And we're certainly paying special attention to any symptoms that they're having at the current time, and especially if we know their past medical history, or we know something that might have led up to the crisis they're having at that current time. We look at personality factors. We look at any kind of recurring issues, the students that we call our frequent flyers that are coming in, or we might have talked about at one of our meetings at the building. and anything that might be a recent issue. And I know this might sound a little strange, but I actually tell school nurses to look at the police logs and to read the not so nice newspapers. I won't name names of which ones, because there are different stories about them. Like, for example, we have a lot of teachers that live in Massachusetts, don't get the local paper. And that's just one of the things that could be a clue. The next thing you know, the kid's in a crisis in their office and they had no idea what was in the paper the night before. Or in this case now, on Facebook. So those things can be very helpful. I mean, it works really well for us in the schools that we do see our kids, you know, as opposed to when I worked in the emergency room and they were just, you know, out of the blue coming in. I had no idea about them. So, of course, if we think that suicide is high, we activate EMS, or usually in the school systems, we go with the SRO first, but it depends on where you are. We always make sure the parent or guardian is notified, and the big thing, we don't leave them alone. We do, if a student is coming down to us for whatever reason, if it's substance abuse or if it's suicide, we always have a policy that the administrator must go and get them from class and bring the backpack with them. It's always good to acknowledge what the student is saying to you. We very often do have to help the parent understand how serious it is. And then if it should be a completed one, heaven knows Enfield's had enough experience with that one. So depending on what's going on with your student, this could certainly be the trickiest part. But based on what that assessment is when they walked in the door, and then after you talked with them, you're going to figure out how to continue that talking based on what you assess might be going to happen. You always want to be warm and genuine with the student, but you need to also be calm and affirmative. You want to listen, but not be judgmental. If they are actually talking about suicide, you acknowledge that that is a choice, and you want to try to explore those feelings and discuss alternatives with them. Another one that we also see and deal with is the bullying. It can certainly impact in why we see the kids with the anxiety, with the not wanting to go to school. They start doing poorly in school. They may not even want to walk to or from school because maybe it's someone in their path along the way. They become withdrawn and anxious. They may have even attempted or threatened suicide. And sometimes they can become very aggressive and unreasonable because they don't have the skills to deal with what's going on. So, but the big thing we do need to always remember is that there's always the potential for violence. Was interesting, one of the times that we had the accreditation done for Fermi, one of the sort of pluses, if you will, that we had done was the fact that there were 2 doors to the nurse's office. Because one of the worst things you can do with someone who is in a crisis is to make them feel like they're threatened and backed into a corner. So we always had that back door, which not all nurses' offices have. So just know that it's an abuse of their power. They are learning to protect themselves by joining gangs and getting a hold of weapons. It's a learned, modeled, or justified, just as you talked about, or the PSAs talked about with the alcohol. They're rarely violent just to be violent. And then we have a table that we use that shows characteristics that are predictive of violent behavior. So if we have an incident, we do have policies and procedures in place, but you know, it's very easy to have policies and procedures and try to put them in place when you're in the moment. But always just to know that scene safety is always the priority, and it is part of the assessment, So basically that means that, if the student comes in and you're looking at that head to toe, you're looking to make sure, do you see, a bulge that might be a weapon or something along those lines. Making sure that there is administrative support with them. As I said, that they have to bring the student to us and then be there with us, and certainly not to approach the student unless it is safe. Like if you're called to an area, we've been called to parking lots and classrooms and outside. So keys that can be helpful so that it doesn't escalate. You never want to invade their personal space by getting too close. You also don't want to stand directly in front of somebody because they find that very threatening. So you're better off to stand to the side. You don't want to stand and block the door. So if I was trying to evaluate Jean, I'm not going to do it from standing in front of that door there. You want to try to have an open posture, not to let them know that you're trying to be in charge. Try to get them to maintain eye contact with them. You want to always, as we can't stress enough, the scene safety. You want to be able to move quickly, but avoid any sudden moves that would actually scare the person that you're dealing with. And then you also want to make sure that you know how to get yourself out safely. So if it's not actively violent, you want to make sure you talk in low, measured tones with them. Again, making sure that you do verbalize some empathy with them and that you want to try to help them. So very often we could say to them, what can I do to help you with this that you're dealing with? We would say what it was. Sometimes it helps to walk while you talk. They are not usually wanting to sit down. So it gives a much more relaxed atmosphere as you're trying to make that assessment to walk around with them. We've even been known to go outside and walk around the building, if it's safe, always if it's safe. And to restate what the student is saying to, you're feeling angry. What is it you feel you need to do? So again, we just need to always be aware that violence is real, making sure you have policies and procedures, make sure that you're following the zero tolerance policy. It's good to have support groups for students. The big thing too is making sure that the staff knows how to deal with these situations and try to de-escalate them as opposed to making them ramp up even more. And as always, peer counseling and mentor programs help. And unfortunately, we're getting more and more what they call laws that are just for one thing. And that makes it difficult to do everything else that you have to do when they have a mental health law that's just for about one thing as opposed to a lot of things for the behavior of students and our youth. So just knowing that, unfortunately, mental and behavioral emergencies are inevitable. Planning and preventative measures, you might be able to avoid some tragedies. One of the big things Jean and I worked at was our ever-famous return to school forms. Because in my first year as a school nurse, I had a 5th grader with an active suicide, and I couldn't believe that he just came back to school with no plan. So it was one of my personal ones to do. Not that we wanted to know, everything about it. We wanted to be able to have him safe at school. And for him to know what to do if he didn't feel safe at school. And also for the teachers to know how to help him. So just make sure there's good communication techniques. Again, as we talked about, knowing what is normal growth and development, which changes as society changes. And just knowing, again, if you do have a problem, what are the professionals and resources that we have to deal with that? And I would say overall, I think we've made a lot of progress. We do, yes.
I have a question.
Sure.
A few slides back, you had, been speaking with someone who's in a crisis situation. For the layperson,
Mm-hmm.
maybe a coach or someone in the neighborhood, you have that issue
Relationship.
bubbling up.
Yep.
You ask, what you can do to help. And the response is, nothing, leave me alone. Without asking you to get into a full role play.
Yeah.
What is the next step from there?
I guess it would depend for me on the age of the person and my relationship with that person. But if I, had that gut feeling that nurses get, I probably would go to either the parent and say, gee, have you noticed that Johnny's doing this, that, or the other thing, or not playing with other kids, and give the parent that opportunity to say, yes, I'm noticing this, and, we're doing this, that, or the other thing about it. And then if they don't, then I might pursue that a little closer and say, that's something you might want to bring up to your pediatrician. I always start with pediatricians because to say you need to get your kid to a shrink
Right.
will just offend them, everybody. So the pediatrician's always like the first place to start. And hopefully if the kid has been going to the same pediatrician, whatever, and the mother calls or the father with the question like that, then, they may look back at their notes and say, oh, this is a change. You need to bring Johnny in and let's do a little more with that. And now that the pediatricians and other people do have nice little easy surveys that they can do to get a better feel for it and see where to go with it.
Okay, thank you.
Yep.
Something I witnessed this morning, and I'm just curious how much you're seeing it in the schools. Caffeine, and I don't remember students bringing
Right.
giant coffees to school, but I watched a kid this morning buy 4 of the little energy shots at
Yes.
the convenience store, and clearly that was all he was buying for the day.
Yep.
Is that
A
being
real
seen
problem.
in school? And
Yes.
how is it?
We don't have an actual policy. It's sort of more a practice that we don't allow them in schools. So if we do see students with them, we do take them away. But it is also a concern too because we have parents dropping kids off with huge Dunkin' Donuts and stuff. And I made the mistake of saying, we don't really allow that in school, and having my head bitten off by the parent. But it's more the kids that the parents not involved with that the kids like stopping at the convenience store on their way in and doing that. And sometimes, depending if they're new on it, they may end up in the nurse's office because they're going to get jittery and whatever, especially if they do all 4 at once. But a lot of times, this is the kid's routine, and so it's not being picked up.
Are sleep disorders something that you would deal with
Yes.
often?
Often. And, we never used to see that as much with kids, but that has really changed, so much so that, like, the Children's Hospital has a whole sleep clinic now because all these kids have problems sleeping. A lot of our kids don't have what you call self-regulating, so they didn't learn when they were babies how to soothe themselves and go to sleep. So now they're in school and whatever, and they can't get themselves to go to sleep. So now the parents are buying melatonin because you can over the counter. And we've just got like a vicious cycle going on with that.
Thank you.
Behavioral health screen on the school nurse on the physical.
On the physicals, we haven't had any luck. Yeah, because for whatever reason, I don't know whether it's a printing issue that if we change the form, it's going to cost them more to add that. But I did just for kindergarten. It took me a while to read it, but it was a pediatrician from Tolland who wrote in what assessment he did, and that the child passed it. It was the first one I've seen. So I think the word is getting out there that they need to do more of this in the pediatrician's office, and depending on the person, they're either going with it or they're not. But I thought it was progress that you got one today.
It is. We'll take it.
We'll take it, is right. That was good.